So we're going to get onto something a little more pedestrian, but I think of more interest. There's a lot of gray area in spine surgery, in case you didn't realize that. There are obviously, people who don't need to see spine surgeons. There are people with cauda equina syndrome or acute myelopathy who need urgent surgery, but in between is a very big gray area that we live in. So there are a lot of conditions that can be treated different ways. And there are different treatment methods that have reasonably good scientific basis for doing them. That's clinical EquiPoise. So what we thought we would do is have a couple sessions where we present a case and ask two experts how they would address it, sort of loading the situation, knowing that they would choose different tacks, but harvest their thoughts for a 5-minute presentation for each one. So these are the three entities. It's single-level cervical disc disease, multi-level cervical myelopathy, and then grade 1 to 2 Degen Spondy with stenosis, and asking two surgeons for each. So here's just the first, prototypical case. It's not a case they had to address specifically, but, 36-year-old with single-level unilateral cervical radiculopathy, failure of 3 months of conservative care, soft disc herniation with root compression, who's miserable and is interested in a surgical intervention. So we picked two of our favorite surgeons, Dr. Rick Sasso, who I know is more frustrated than we were last night because he couldn't get in, but he's on now, I think. Rick, are you there?
Yes, can you hear me, Jack?
Rick, I'm disappointed. I thought you'd be wearing your TBI scrubs. You let me down. So Rick is going to talk about.
I had him on last night.
Yeah, good. Rick is going to talk about what I know is his favorite operation, ACDF, and then Scott Blumenthal is going to do his favorite operation for us. He'll tell us why he would have done a disc replacement. So go ahead, Rick. Thanks again. Thank you for trying last night, and thank you for being with us today.
I was taking the presenter's prerogative to mean, Jack. Now, I see that you presented a case that had radiculopathy, but a lot of times this code word DDD means neck pain without neurologic issues. And that is something that I strongly believe we should refrain from using these new technologies, specifically arthroplasty, thinking that we're going to get as good results as we did with our IDE trials operating on patients with neck pain. And unfortunately, that sometimes is what we see when our technology gets out into the world after it becomes FDA approved and we call standard of care. It's important to remember that the inclusion and exclusion criteria for all of these discs were mainly this single level, except for later on there were some two levels. They had to have a neurologic deficit, radiculopathy or myelopathy. They had to have a floor of an NDA. They had to have a significant disability, no previous cervical spine surgery, and excluded were deformities, significant degenerative changes in what likely knocked out most of these patients in the IDE trials was a disc collapse of more than 50% and obesity. And with that criteria, this is the first case that I did 22 years ago. This was the first patient that had a cervical disc replacement in the US. And almost all my patients looked like this, very, very minimal degenerative changes. They had a focal disc herniation causing a unilateral radiculopathy with a fairly well-maintained disc height at the appropriate level. And with this indication, we have had remarkable results out to 2 decades. And we published this just last year with very, very high follow-up rate, over 90%, with significant improvement actually in both groups in regards to NDI out to 20 years, VAS of the neck and VAS of the arm as well, showing significant and profound improvement compared to preoperative levels all the way out to 20 years. And what was interesting that we found is that although there was significant improvement in both groups, there was not statistically significant changes between the groups at 20 years. And even if there was statistical significance, it would not be clinically significant in all of these patient-reported outcomes. But what we did find that was different was reoperations. And we've talked about this a lot now. And as longer follow-up occurs, we see that this is the significant difference between the groups. And at 20 years, we had a 10% reoperation rate in the arthroplasty group, over 40% in the ACDF group. And what is really interesting for me, at least in this ID trial of ours, no patients had a target level reoperation. And even in the ACDF, less than 5%. And that was for asymptomatic pseudoarthrosis. What is really interesting, though, and I want to show you this data to give us some pause. So what we looked at, and we just, our fellows just looked this up, this probably will be published within the next year. At this blue line is trial. So I was involved in 9 cervical arthroplasty FDA IDE trials. When we look at the success rate or survival rate out to 10 years in the patients that were in the trials, as you see, it was very, very high. We have a high survival rate. But when we looked at the standard of care group, so this means the patients that after the disc had FDA approval, looking at those cases that were done in our surgery center and in our hospital by other surgeons under standard of care, the survival rate profoundly worsened, especially at 5 and 10 years. And when we look at, so this is at the target level, when we look at non-target levels, same thing. Fairly high survival rate at all levels out to 10 years in the trial patients, those patients that were operated on under a trial with very specific inclusion-exclusion criteria. And when we get, when the disc got approved and was used under, quote, standard of care, so maybe not under very, very narrow inclusion-exclusion criteria, the significant failure rate that we see out to 10 years. And what is most concerning to me is this information, looking at patient-reported outcomes. So the trial patients in the blue all started worse than the standard of care patients and ended up at 5 years better than the standard of care. So not only are we seeing higher failure rates at the target and non-target levels, but also worse patient-reported outcomes. So when you expand the indications from those of the original inclusion-exclusion criteria, do not expect to see the same great outcomes that we see in these trial patients. So just some caution. So thank you so much for your time and attention.
Thank you, Rick. That's there's sobering data, and hopefully we'll have a little time to talk about it as well. Can we get Dr. Blumenthal's slides up?
On the opposite of debates more often than not, but I don't know that we're going to differ too much today. While we're waiting for my slides to come up, Rick, an interesting study would be to take the control fusions from the IDE trial and compare them to a similar group of just cervical fusions done outside of the trial in your same facilities to see if that difference would be the same. I don't know. All right, so I'm kind of pretty much stick with the assigned topic of this very typical case as we've talked about before. Obviously, cervical disc replacement now has, as Rick demonstrated, over a 20-year history in the US. And there are studies that I'm not going to spend a ton of time on from our US IDE trials to all over the world that kind of will confirm that at least as good and in many outcome measures better than fusion, and that's what I've been tasked with. One of the things you can do, and this is not science, is follow the money. And the cervical disc market projection is huge, as you can see, with a compound annual growth rate in this decade approaching 20% a year. Now, it's substantiated, as we talked about, and I think Jens alluded to earlier, by really one of the most studied technologies around. I mean, this is the literature, the peer-reviewed literature over the last a few decades, and it has just exploded. This has resulted in the approval of many discs now in the US. And the reason why this technology has been pretty darn successful is the reproducibility of results. And this is one of my favorite slides because it shows the NDIs of all the IDE trials, including the fusion controls for as long as follow-up has been reported. And you can see that the results are very, very repeatable. So highlights from the literature of disc replacement are meta-analyses, and we have many, many meta-analyses looking at predominantly clinical outcome, but also other outcome measures, as you can see here. A couple of the more recent studies and comprehensive, a lot of this reviews come from Asia. They're really good at putting together meta-analyses. And this is a study of 14 meta-analyses. Only randomized control data finding cervical TDR was superior compared to ACDF for the treatment of symptomatic cervical disc disease. Again, another study looking at 8 clinical trials, 15 papers, thousands of patients. And really, the take-home from this, and this is really unarguable, all these outcome measures that we do for the most part, including neurologic assessment because there's inter-observer reliability, have some degree of subjectivity to it. What does not have a degree to subjectivity is the incidence of secondary surgeries. That is just a data point that there's no subjectivity to that. 10-year outcomes, and obviously Rick has 20-year outcomes, but this is a 10-year systematic review of randomized controlled trials as well. And no parameter was ACDF superior to TDR, either statistically or clinically. So what kind of technology has this kind of data? The answer is, aside from maybe lumbar TDRs, nothing. We wanted to kind of get an incidence of revision rate because that's obviously one of the, the survivability statistics that Dr. Sasso was reporting. So we used our case series at TBI, which is accumulated in our electronic health records, 1,600 cervical disc patients that had at least 2 years or more follow-up, many of them 10 to 20 years follow-up. And we have a number now, at least something in the literature that says that at least in our case series, the revision rate was under 1.5%. Patients ask us that all the time because they hear about hip and knee replacement revisions. And this is kind of a comparator to a large study that was published in Lancet on modern technology of hip and knee replacement. So it really does compare favorably with our hip and knee colleagues. I thought Christoph Hofstadter was going to be here, so I put in a few comparator slides on posterior foraminotomies because that's a motion-preserving procedure and perhaps, a better control for cervical monoradiculopathy. And these are some studies in the literature. And again, you're going to see fairly similar situations. Interesting enough, the op time is greater with anterior surgery, but posterior surgery doesn't include positioning in their op time, and I think that may be an unfair comparator. Outcome measures do favor disc replacement. Another data point, complication rate was higher with the anterior surgery, but of those 24%, 20% were transient dysphagia, which we see with our ACDF patients as well, which may mean just kind of a sore throat for 2 days as it's reported. But again, revision surgery rate much higher with posterior surgery. Looking at another paper, cervical radiculopathy, a meta-analysis of trials. This includes disc replacement, fusion, and minimally invasive posterior foraminotomy. And the posterior foraminotomy, again, had the lower complication rate. Again, this transient dysphagia, which has to be reported. Of the 3 groups, TDR had a significantly lower reoperative rate. And finally, another big study of just foraminotomies, and this is a fascinating thing for the proponents of foraminotomies. If you look at up to 2 years, nearly 10% reop rate, greater than 2 years, 18%, patients with greater than 10-year follow-up, 24% reoperation rate from posterior cervical foraminotomy. But if you do like to do it, pick patients with no neck pain because those did better in this trial. And unfortunately, I usually don't see patients with just arm symptoms. Most of them do have neck pain. So concluding, disc replacement produces similar or superior diffusion or foraminotomy, protects adjacent segment, and is associated with significantly lower reoperative rate. And now we're seeing 10, and now with Dr. Sasso's study, 20-year follow-up of prospective TDR studies from US, outside US, and these successful results have been maintained. And I will agree with Rick, in properly selected patients, we all know that that's the key. So if you think cervical arthroplasty for those properly selected patients is the gold standard, I believe you're correct. Thank you.
Thank you, Scott. Anybody have a quick comment or argument to make? I think, there are conditions where there's not going to be a clear-cut single answer, and there may be options available, and surgeons, there's still an art to what we do. So, surgeons should still recommend what they feel is going to do best in their hands, but it's always nicer if it's backed up by data. Dr. Bourbon.
Yeah, Jack, to Rick and Scott, terrific presentations. Rick, I want to make it clear that it was not any type of interference from me remotely that prevented you from participating in a debate last night. Glad you're with us today. I think you and Scott concluded that indeed in properly selected patients, this works well. But when you reduce the selection criteria, indeed, it really doesn't do nearly as well. And I thought that your SOC patients, as you term them, that was pretty disappointing to see how the generalizability was outside the study. So to that end, it seems pretty clear that we need to identify some more granularity to the diagnosis and figure out what we're presenting as means. And one of the things I talked about last night is that the mean doesn't really matter. What happens is the individual patient. So what are the specific criteria you think that might have been violated in the SOC patients compared to the study patients? And so is there a subset that we can identify that maybe it's a cluster that we should be avoiding disc replacement on, where a fusion might be better? And what are the specific characteristics of that cluster?
Yes, Sig, that's a great question. And unfortunately, this study is not that granular that we can determine what was really different in the standard of care patients compared to the trial patients. I think my hunch is that the diagnosis was not as clear. Specifically, the patients didn't have a discrete radiculopathy or myelopathy. They had more neck pain. Again, that was the topic was DDD. And again, sort of where I'm from, when you say DDD, that's code for they've got axial pain. They've got axial neck pain and not a specific radiculopathy. My hunch is there were more patients in that category in the standard of care.
Rick, would also be nice to know whether there were surgeon factors, with the worst results in surgeons who did less than 5 a year or 10 a year.
We're looking, you're exactly right, Jack. We're looking that up because clearly those that were in the trial that had limited number of surgeons, right? Only those that were in the trial, and what I call, usually they're the hyper-technical surgeons, right? And these are incredibly selected patients operated on by hyper-technical surgeons. And the problem is when these become FDA approved, you have not so great selected patients operated on by maybe not so hyper-technical surgeons. And I think we all understand that probably the results are not going to be that great. And this is some objective data that we're just putting together to show that our hunch is right. The results aren't that great.
Right. Well, you asked the question that I was going to be my comment to follow Rick's. I don't know that we looked at it on the cervical study, but in the lumbar study, the revision rate were much higher in early learning curve surgeons, and it's a tough thing to put out there, but it's like any other field. The high volume heart surgeons have less mortality than low volume. I mean, we see it in hips and knees. And why should we be any different in spine? I don't think so. And again, I'm going to agree with Rick. why is cervical arthroplasty more well accepted than lumbar? It's because it's easier to make a diagnosis. If you're doing cervical arthroplasty or an ACDF for neck pain alone, we're back to the same problem we have with lumbar. How do you pick which levels are the ones that are hurting?
Well, thank you, guys. That's a great discussion of a very common pathology and, kind of give everybody a little bit of extra thought. So let me move on to the second case and get two surgeons. We can. You want to lead the vote?
All right. Case that Dr. Zigler showed before. Who wants to have a disc replacement? Show of hands. Who wants to go with Dr. Sasso? Tried and true fusion. Sorry, Rick, not good.
Oh, poor Rick.
We love you. We love you. We
All
very
right,
much
Jens, can I change it a little bit? Raise your hand if you had that exact same MRI scan X-ray and had neck pain without radiculopathy. How many want an arthroplasty? With just neck pain. Okay.
I think the point is if you're going to bite off and do surgery alone, and you said, I'm going to target that disc, it's still a leap of faith because you're not going to have as good a result from axial neck pain. And I'm sure you tell your patients the same thing, whether it's an ACDF or an arthroplasty. So, again, pick the operation that you're good at.
Should there, again, be more granularity to that? Because, again, neck pain is not a diagnosis. So should it be flexion-mediated pain, extension-mediated pain? To me, the real problem that we end up with not being able to show a difference is because we're clumping together things that should be clustered separately. And I think your point's really important, Rick. So I would definitely fuse somebody with neck pain if I didn't have a very clear source of pain. If I could prove it was flexion-mediated pain and a symptomatic disc, sure, I'd do a disc replacement. But it's very difficult to actually make that distinction in somebody with neck pain.
Yeah, and the nice thing about ACDF, it fixes all sins. So, whether you have posterior column pain, instability, collapse, compression, malalignment, you fix everything with one operation, and we've gotten lazy because we have not had to make that discrete diagnosis. Arthroplasty, because it magnifies the surgeon's sins, you really have to be much better at making the diagnosis, and maybe, again, that's what Rick is saying, that specific diagnosis wasn't appropriately made in some of those cases. So it's good discussion. All right, here's case number 2 is a 56-year-old woman who comes into your office stumbling, with an unsteady gait, and you examine her, and she's clearly got a myelopathy. She has long tract signs, numbness and tingling in both hands, and is looking for help because it's progressive. So I think we have Dr. Chris Kepler on the line. We do?
Yeah.
Great. Chris, thank you very much for joining us. And Chris is going to talk about doing a decompression laminectomy with or without a fusion. And then Dr. Chapman is going to talk about one of his favorite procedures, which is a laminoplasty as a motion-preserving way of addressing this. So here's another case where there's different ways to address it and literature that will support you either way. So let's hear what the experts say. Chris, thanks again.
And is the screen share working?
Yes.
It is. You're up.
You can hear me. Okay, great. All right. So PCDF for treatment of cervical spondylotic myelopathy. Side note on that, the case you showed, I may do an ACDF. But let's say that there's one more level down below because it also makes it harder for the laminoplasty. And really, PCDF is a known quantity. I mean, it's been around a million years. And so a lot of times I think that in the context of this debate, it's a little bit more like there's not a reason to do something different. And we'll talk about the reasons for that. So laminoplasty really is an operation in search of someone who actually needs it. And these are the treatment goals for any posterior-based surgery or any surgery treating spinal cord compression, which is decompression, number 1, stability alignment, either maintain it or restore it if possible. You want minimal morbidity always. That's, goes without saying for every surgery you think about, and maximal durability. And there's a number of these points where I think laminoplasty falls flat. These are the purported advantages. Muscles saved, I should put that in quotation marks, and then reattach that in quotation marks as well to the posterior elements. Preserves normal motion, preserves alignment, and then has, in some people's minds, improved neurologic outcome. I think there's a big myth about that muscles reattach to the posterior elements. I mean, And you can look at post-op MRIs from either procedure and see that all posterior operations result in innervation and atrophy of the extensor neck muscles, particularly multifidus, which gets beat up. And, as careful as you are trying to find the fascia, which is unevenly split, a little bit thinner here, a little bit thicker there at the end of the operation, what you're really doing is just creating the belly of the muscle scarring down to the posterior elements. The tissue preservation or the tissue sparing probably centered mostly around C2, which can be, by and large, the muscle attachment C2 can be saved with either procedure. The preservation of the subaxial midline ligaments, like in my mind, is like a little bit of a joke. Like this is like tissue paper. If you look at like there's no robust interspinous or supraspinous ligaments in the cervical spine. It's all about the fascia, which is there either way. And so I don't think the subaxial midline ligaments are anything to write home about. There's a myth of laminoplasty preserving normal motion. Like certainly it's motion sparing. Unless you get a non-union, you shouldn't have a lot of motion after PCDF. But the numbers as far as how much motion you actually preserve are not as impressive. You tend to lose 40 to 50% of the motion, and these are sort of the old Masters series. If you can find out Dr. Morimoto, that's probably the guy to go to because he only loses 17%. This is, at this point, this study is aged a little bit, but it's a huge, huge retrospective case series of 2,500 patients done by Ratliff. And kind of the same story. There's a high incidence of worsening alignment, even with a, not zero incidence of kyphotic alignment, which, stands to reason some of your benefit with there's anterior spinal disease, an operation which ultimately leads to either a neutral spine or kyphosed spine. You may lose whatever benefit you got from a posterior-based surgery. Sort of the same story. 20 to 30 to 40 to 50% even of worsened alignment. That doesn't mean that they're kyphotic, but not as good as you're going to lose some of the benefit of decompression with worsening alignment. A number of authors have noticed that this is kyphosing. You can only hope to have better sagittal balance than your upright x-rays in the office with PCDF. You can't pull a laminoplasty back because it's only pulled back for your hour and a half long operation, and then they're back where they started. And so there are certain patient populations who will not do well with laminoplasty. Question about how many fail to remain open or sort of don't achieve full decompression. One of my partners thinks that number is as high as 25%. He's the one who does the most in our practice. That number, I hope it's not that high because that is, if the primary purpose of your operation fails 25% of the time, probably we shouldn't be doing it. C5 nerve root dysfunction, is probably similar, maybe a little bit lower than 8%. Axial neck pain is really not that, you're not winning on axial neck pain. High rates of it, no difference in the long term from any series between laminoplasty and PCDF. And that makes sense, right? I mean, PCDF is not a perfect operation. It's people do have a ton, especially acutely, people hate it. It hurts a ton. But when the dust settles, you still move through arthritic spine. That spondylotic spine, the disc degeneration you showed on Dr. Zigler's case presentation slide, those discs aren't going to not hurt you after laminoplasty when you're still moving through them. So failure to remain open to sort of address that. Doesn't make sense to have an improved neurologic outcome. They both decompress the spinal cord, but there's no doubt with the laminectomy. You're looking at the spinal cord side to side. As long as you're not narrow, you absolutely have decompressed it to the extent possible with a posterior-based surgery, and you have no concern about loss of a line and maybe backsliding as the laminoplasty patient becomes more neutral or potentially even kyphotic. Several recent direct comparison, which really show no difference. Function, pain, quality of life, satisfaction, again, but you don't lose ground over time. And so I think the claims of tissue sparing is largely fake news. Complication rate and outcomes seem similar. Like, don't be a hand surgeon. Like, who wants to be putting 1 millimeter screws in as an orthopedic surgeon? Luckily, surgeons aren't fooled. There has not been an increase in laminoplasty rates over the past 10 to 15 years. It is about 15% of posterior-based surgery or a little bit less. And like in my mind, like given the limited indications of people who I think would benefit from this, I bet that's about right. Thank you.
The hand surgeon has taken the podium, and I'm proud of it. And where is my talk? Background, sorry, need help?
Needed it.
Chris, I am a strong admirer of you and your program, and your pragmatism is unparalleled. Love your presentations. I'm going to make the case for laminoplasty, an overlooked procedure. At this point, I have no conflicts of interest. And again, case presentation for me, 67-year-old male, very active, doesn't want to age, and very well-to-do. And carpal tunnel releases, actually a common story for these myelopathy patients. Rotten neck, multi-level disease, C3 to C7-ish, but mainly C3 to C6. And again, I'll just ask the audience here, and then I'll ask you, what would you want to do? Multi-level ACDF, show of hands. Dr. Martin, multi-level ACDF? No takers? Come on, Dr. Alamin.
Say multi-level ADR.
Say multi-level ADR, 3 or more levels. Oh, there are a couple of ADR guys. Okay, I said that. And Chris, just without knowing anything else, very well-to-do, fit guy, can't
if I can
age.
convince him.
Huh?
You got to convince a guy that this fusion at a couple levels that are already collapsed is not the boogeyman. He's not going to lose ground.
Okay, this is the premise. Healthy spinal cord, we all want it. Progressive CSM is one of the leading disorders of spinal cord dysfunction, and it's a form of silent, without being dramatic, spinal cord injury, which affects a lot of people. And we have to be clever and thoughtful about this. And the cord is a viscoelastic structure that is surrounded by a hydraulic system that requires a pumping of fluid, cocaine and a half plus, from brain to sacral plexus to basically function properly. So we all want that. We all know that from the viscoelastic tendency, having a harmoniously decompressed cord surrounded by this fluid is very desirable. And we obviously need to know alignment, instability, stenosis, and again, arthropathies or inflammatory diseases. So without a question, the premise is very clear, and we know that cord tension and compression and forward flexion is bad. I'm going to flash the next 6 or 7 slides very fast, but I was privileged to be one of the originators of the myelopathy prospective observational study, anterior versus posterior. The demographics, all doesn't matter. We did show that on all aspects, cord function, et cetera, surgery did work. And this was anterior and posterior. Now, this was cool. It was not a cure, but there was a substantial over 2-grade improvement on all scales, and even pain improved somewhat. All comers, anterior and posterior. Anterior versus posterior was interesting because there were no real differences in our group between what happened. Again, there was something interesting then. In the posterior part, we allowed fusions and we allowed laminoplasties. And again, in the posterior part, anterior versus posterior, again, there was the expected dysphagia, non-union risk greater with anterior surgeries. But when we looked at the posterior data, which again included posterior fusions and included laminoplasties, which we just put in for completeness sake, we saw that the laminoplasty group had the same neurologic outcomes, but had way lower complications. And this was a prospective observational, relatively well-powered study. We found that 1 to 2 level disease in North America was preferably treated by anterior surgery, and multi-level disease was better treated with posterior surgery in that era, in that day. This is now an almost 2-decade-old study. Again, posterior choices were laminoplasty versus fusions. Now, there were clear reasons to do fusions, and there are clear reasons to sometimes think about a laminoplasty. Low morbidity procedure, there are clear contraindications: instability, inflammatory disease, fixed kyphosis. You mentioned them, so no question. But if we look at the macro data from my perspective, within 30% normal range of motion, loss of lordosis, probably 8%, muscle activation significant, and the Japanese literature, 30% historical data. So laminoplasty versus fusion, lower blood loss, longer surgery with fusions, higher infection rate. These are all factors in our series. More recently, the EquiPoise trial by Zohar Gogavala, fantastic study, 2014 to 2018 EquiPoise trial. And again, the key thing, if you look at this thing here on the laminoplasty, which is the light blue thing, there was a single patient in that study. This is right here where my cursor is. Do you see the cursor? No, you don't see it. Yeah, you see it a little bit. There was a single patient who deteriorated in their prospective study. All other groups had some problems with posterior and anterior surgeries. And again, clearly, of all complications, laminoplasty was by far the lowest, anterior versus posterior. This is in our AAOS, one of our cardinal spine refresher things. So dysphagia risk was the leading problem of multi-level anterior surgeries, 18%. And there are multiple other studies that have now come out. Patients with laminoplasties go back earlier. Problems with laminoplasty. too many different techniques. Every prefectura in Japan has its own little technique, and none of them are really rigidly fixed. The old unilateral versus French door, that's a complicated surgery. This is, I think, for us nowadays resolved. Unilateral hinges and our hands are much better. It's a fickle procedure. You ridicule this hand surgery. I actually agree. It's a very technical procedure. There's no question. Every little detail matters, and it's not something cursorily. So too much variation, and it's a fiddly surgery where you have to be willing, with fine hand motor control, to put in 2mm screws, no question. And then there is the real elephant in the room. I took the elephant out here. The reimbursement. Right side, reimbursement codes typically used for posterior multi-level fusion. Left side, a single code. Doesn't matter if you do 3 or 5 levels with instrumentation. A quantum leap different in terms of in favor of fusion. So if you want to look at that, it's a factor. And single or 2-level disease, absolutely no question. Disc arthroplasty, expanding the horizon maybe to 3 levels, okay. Complex neck problems, no question. Anterior posterior fusion surgeries. Now, let's come to the resolution. 67-year-old male, very well-to-do, can't go on. I did a laminoplasty on him. What is the outcome? 10 years later, he's 77 now, still loves me, gives very generous donations, and still goes crazy. His low back is his big problem now. So that's what I did. The problem with laminoplasty that I think in terms of myofascial pain is real. Doing quality posterior fascial reconstructions, you hit it on the head, Chris. We agree. It's essential, and we have not done a good job. Myofascial dehiscence, the delta wing sign, the trapezius dehiscence is a real deal. We have to be better soft tissue surgeons in terms of repairing the posterior tension fascia, especially in the lower C-spine. Laminoplasty, preferred option, multi-level cervical spondylosis and stable neck with straight or lordotic alignment in healthy-minded patients who want to return to activity. It's my go-to surgery. I absolutely love it. And yes, posterior fascial reconstruction, aside from a meticulous technique, is good. So it's not only a hand surgeon's skill, it's a spine surgeon's skill, and it's a plastic surgeon's skill in terms of repairing the soft tissues. With this, I close. Thank you.
Thank you, Dr. Chapman. The oxygen tank is right over there. So again, we see different ways to approach it, reasonable data on both sides. The laminoplasty data, as Dr. Kepler mentioned and Dr. Chapman did also, the older data often did not use instrumentation. I think there was a definite change when instrumentation came into vogue because we could get patients out of a collar quickly and rehab them, and a lot of the soft tissue issues, particularly the neck pain and the stiffness, got dramatically better from a patient standpoint once instrumentation came in. So, and something we discussed last night, I think at a teaching institution, a multi-level anterior procedure is very difficult because the surgeon's the only one who really has visualization, and that's usually, a trainee, you have an attending, you have sub-trainees who see nothing, whereas with a laminoplasty, everything is open. They see the anatomy well, learn pathology, learn how to use instruments, and then once the spinal canal is open, they get the reward of seeing immediate expansion. So that technically, I think it's a very good operation in a teaching institution. So I'm glad we had both sides. Can we do a quick vote to make Dr. Chapman happy if, God forbid, you had multi-level cervical myelopathy from stenosis and needed an operation? Who would want a decompression and fusion a la Dr. Kepler, East Coast? Show of hands. Chris, close your eyes. And who would consider a laminoplasty coming up to Seattle, visit Dr. Chapman and get a laminoplasty?
I think they were both excellent presentations, but as a low RVU surgeon, I would go with the low RVU procedure.
Wow.
All right.
So, Jack, as we're transitioning, I think once again, we're kind of clustering the cervical myelopathy patient and the subset of patients who've got kyphosis, who've got perhaps preoperative kyphosis, who have a more severe myelopathy. I think I would go with the laminectomy fusion on that. But in the case that you showed, I think laminoplasty, the patient with no neck pain, a patient with reasonable alignment, I think the Corey study is pretty compelling, as Jen suggested. But again, I think part of this, I was one of the arbiters for deciding which cases were appropriate to randomize. And there were a lot of cases that really weren't, where there wasn't EquiPoise. I think that's really important, is understanding where there is EquiPoise. I would favor a laminoplasty, but there are a lot of cases where I'd go anteriorly or do a posterior fusion. And we really need to make that distinction in the granularity of the diagnosis.
Thank you, Sig. So here's the last of ours, and we have a lot of discussers. Just a quick change. Dr. David Ye is going to discuss the Coflex instead of Jens. So this is a 56-year-old woman with a grade 1 to 2 degenerative spondy at L4-5. And as Dr. Marnay, I think, had mentioned in his, Dr. Marnay mentioned in his talk, can't do that. The artificial disc replacement in Europe has been used for this, and we've been a little reluctant here in the U.S., so be interested to hear his take. But let's move along because we're falling a little behind schedule. I'm going to give mine because I'm on the same thumb drive, the same program here. So let me just jump ahead. And I was going to be the third speaker, but I'm going to talk about using indirect decompression with interbody fusion for Degen spondies of grade 1 to 2 for both decompression and stabilization and see what is the data for that. There's a lot of evidence, both cadaveric and radiographic and clinical, that shows that, just as we've done in the cervical spine for a long time, that you can do a lot of decompression and stabilization anteriorly with appropriate interbody carpentry. So, why not transfer that to the lumbar spine? It was one of our older partners, Dan Bradley, who I think originally started practice in Seattle, came down to TBI for a while. Dan started doing that on patients, and we were like looking at him cross-eyed, but then he started showing results were quite good, and this has become kind of the house operation at TBI for Degen spondy for many of us over the last 15 to 20 years. So the rationale is by opening up the disc space and reducing the translation from the front, you increase foraminal area, which should help the patient's radiculopathy. It clearly can increase the volume of the spinal canal without having to directly get in and remove ligamentum flavum and facet capsule, which helps the stenosis. And you have several approaches to do interbody fusions, and there's varying degrees of comfort from surgeons as to how to do that. But my task today was to really talk about A-lift and not O-lift, X-lift, or a T-lift, which is kind of more direct. Interestingly, we have this huge database at TBI, and we've been able to harvest it to kind of go back and look at our data, because the question always is, okay, if you guys do this indirect decompression with an A-lift, how many patients do you have to go back and then do a posterior decompression because they still have either claudication from central stenosis or radiculopathic pain because you didn't do a good foraminal decompression? Okay, it's a reasonable question. But after several hundred patients, Peter Derman, one of our young partners, went back and pulled out the data, and I'll share that with you. So he looked at 568 consecutive patients that we had done since we drank Dan Bradley's Kool-Aid and started using this operation of single-level A-lifts without posterior instrumentation, or with and without, over a 5-year period. So 247 we addressed with standalone A-lifts, and 321 we used supplemental posterior percutaneous pedicle screws. Peter took a look and said, let's see what the percent of those patients is that we had to go back, because he defined failure very clearly. Failure was a return to the OR for a direct decompression. So what percentage of patients? These are just the demographics of the patients. Were no surprise. How effective was it? The clinical failure rate, meaning how many patients had to go back, 4%. So 23 of the 568 patients had a second subsequent procedure for decompression. Often it was a minimally invasive procedure. Age seemed to be the major determinant. Patients who were more than 60 years old were slightly more likely to fail. In that age group of over 60, 7% had to have a secondary decompression, and patients who were under 60 years old, only 3%. So the blended average was that 4%. But if you look at the other side, if the glass is half full, that means that 93% of the people over 60 did not have to have a posterior operation, and 97% of people under 60 did not have to have it. Those are pretty good odds. I mean, this is not flipping a coin. This is, you can sit down with a patient and say, here are the odds that if we do this just from the front, or from the front with percutaneous screws, you will not need to have your nerves opened to the air. some people would say, yeah, but an anterior procedure in older people carries with it its own risks. Well, interestingly, Howard Hahn put together a publication of decade by decade vascular risks for anterior surgery, and his final impression was there is no significant difference, any relationship rather, between age and vascular compromise. Now, obviously, there's some screening that goes on. Good spine surgeons won't ask an access surgeon to operate on someone who's got a stovepipe vascular system, and the vascular guy wouldn't do that. But still, in the typical age group that we see degenerative spinal listhesis, anterior surgery should not be a concern as long as you have an adequate anterior partner. So that's my little segment there for ALIF. So I think our next speaker is Chris Kepler. You still there? Chris is going to talk about decompression posteriorly with no fusion, something that the folks from Rothman have talked to us a little bit about on our interesting case series on Tuesday nights, and we're looking forward to your take on this, Chris. Thank you again.
All right, thanks for having me back. I feel like I'm the foil today. Doing the old boring surgery so you guys can talk about the sexy stuff. So, all right, so lumbar laminectomy for stenosis and spinal listhesis. Oops. So one of the most important things is the doctor-patient relationship. Patients come to us because they have stenosis pain, which limits their ability to walk and stand. Patients don't come in because of instability. They often rarely know they have it. Like, you show someone an x-ray of their back and they're sort of shocked that they have a slip and they never knew it, and because it's a little bit unsettling that something's going wrong that way. We have a responsibility to do the smallest operation that'll help these people. And so I think that, in the context of this discussion, the downstream consequences of laminectomy alone have been overstated by the self-serving spine surgeon community. And we're going to hear from some of those people. We just heard from one. I can't get this. Sorry, I can't. Okay, here. So there's a number of database studies which are supportive of laminectomy alone. Database studies in general are good at identifying event occurrences. They certainly lose granularity for patient outcomes. And they're difficult in the context, again, of the other people who are presenting when comparing different implant strategies, because they're extremely reliant on coding, and you really don't. You can never be sure that things were coded correctly. Now, laminectomy alone is pretty straightforward, and there's not a lot of question about it. This is a NISQIP study. This published in 2021 of just the in-hospital course, and no surprise here, right? Not as much EBL, lower length of stay, lower reliance on inpatient rehab, which are all things which are not really considered most likely in the context of this discussion, because these are things that are more financially important in evaluating the treatments. This is a market scan claim study published just last year. And the question is, because this is the boogeyman, how likely do you think fusion happens after LAMI alone? Again, database study, good identifying recurrence, 25%, 50%, not even close. The likelihood of someone with laminectomy alone with a Degen Spondy in this study is 2.5%. That's minuscule. Oops. So shifting gears a little bit, talk about meta-analysis or systematic reviews. These are better than the small retrospective series you're going to hear from the other presenters in this session, because of the emerging technologies have 25 cases done across 10 different institutions, and you just don't have great data. These retain more granularity than database studies because, again, you're capturing the granularity of each individual study that was performed. And so looking at this study, this pulls 6 RCTs with 500 plus patients. Maybe they're not just recapturing operations, and that's a problem with the database studies. But if you look at this study, which is, again, granular because it's institution by institution, has an identical reoperation rate with a p-value of 1.0 between patients patients who had laminectomy alone and patients who had laminectomy infusion. So the laminectomy in this context, it was not inferior to fusion, and also to boot had fewer complications, as we saw on the inpatients paper. One last study. Then I'll step aside. This is a huge meta-analysis with 37 studies and more than 1,000 patients that compared, and I think Hartle's there. compared to open and MIS Lami. Just to be sure that all these decompressions we're seeing are not just MIS procedures, which have a lower likelihood of leading to subsequent instability. Secondary fusion rates are much lower, obviously, you can see with the MIS laminectomy than an open, but even open group, full-blown, old school, Fred Simeone laminectomy has a likelihood of needing a subsequent procedure of under 13%. And so the conclusion, the need for delayed fusion is a little bit of a self-serving boogeyman. It's our responsibility to pursue the least invasive treatment possible. And if there's some downstream consequences, the question is, who would advocate a surgery that over-treats, meaning you fuse a level that doesn't need to be fused, because only 13% of the time was that going to be necessary? And the answer to that question is these guys, the CPT mafia, who are never satisfied with a single code. Thank you.
Can I ask him one question?
Chris, thank you very much.
Yeah.
Jens,
I just want to ask him one question. So I appreciate that. And by the way, interspinous process spacers are a single code also. So no game there. But point well
I've never
taken.
done it.
One of the key things that I want to know from you is the semantic differentiation of laminectomy versus laminotomy in a slight instability situation. Do you think it matters to preserve the posterior tension band, the PLC, or is a laminectomy just as good?
Absolutely, I would imagine it's matters, and that's where I think if you look at Dr. Hartle's paper, when that distinction gets made, what is it? That was a 4 times higher rate of progression of slip. So I would imagine that it does, preserving the midline structure if you can.
Thanks, I agree.
This is a little bit, honestly. This is a little bit of all my 3 presentations. This one's a little bit of a stretch because I think like a stable grade 1 slip, but then there's a wrench thrown in the case, which is like whatever the hell 1.5 means, but 1.5 grade slip.
Between 1
you
and
start
2.
down the road of probably most people aren't going to do a laminectomy.
Thank you, Chris. We'll see you at the next round, next round table. Dr. Marnay is still on from France, and as I said, Dr. Marnay has been using ProDisc for the grade 1 and maybe a little bit more Degen spondies for many years. So I'm interested to see how far he will allow a translation before he thinks it's not appropriate, and possibly he'll show us some of his longer-term data. Thanks again, Thierry.
The great conclusion of the talk of Chris is that all those surgeons are very good, because as there is no significant difference between the fusion results and the laminectomy results, that means that as it's not randomized, they always have chosen the good solution for each patient. That is because it was not randomized. So sometimes you fuse, sometimes you don't fuse. It's up your judgment to decide, and your judgment is good, because for the moment we have no real criteria to decide. So it's just, excuse me.
Oh, that's perfect.
So just this represents a small series. That means that it's not our standard of care for the GDF spondy, but some cases can be, we can preserve the mobility, restoring the stability, the height, and the motion. It's important to understand that, okay, this series is 60 cases on 3,000 or 4,000 cases of total disc replacement, so it's not the majority of that. Oh, I'm sorry, but doesn't want to work. Okay. So the stenosis, bulging of the disc and osteophyte, displacement, we see that beyond the displacement here, we see the compression from the ligament, because the ligament is too long now because of the height and the displacement. So it must go somewhere, and somewhere it's in the canal. The second point is the facets, and also there we have this hypertrophy of the posterior ligament and the capsula. And we have the horizontality of the displacement. We have the sagittalization progressive of the facets. All of that are criteria that makes us a little bit afraid to not to open, because we have been, all of us has been trained to open the canal and to open when there is a spondy and to fix it. It's an old French school in Créteil who in the 60s started to perform anterior ALIF with iliac crest and plate and screws of that time to treat the degenerative spondy. So it exists for years, but it has never been a standard of care. We restore the stability. It's important to reduce the displacement, redistract the ligament. We open the foramen by our anterior decompression. We open the canal because following what Wolfgang Rauschning was telling us, with the facet obliquity, any anterior displacement make a reduction of the canal itself, and setting back the sliding vertebra will restore the size of the canal. We decompose by anterior approach.
Presentation interference. Thierry, we can't hear you right now.
To see at the end. In this case, in 91.
Anything I disagree with, I just wipe out.
You're being interrupted by the profusion faction.
Okay. Do you hear me? The fact is, here you see this case
Now we see it.
operated in
Okay.
91.
Can you advance your
You see the
slides?
small.
Thierry, can you advance your slides, please? We're
Yeah.
stuck. Okay, keep going. Yeah, keep going. Good.
Doesn't want to work anymore. Excuse me. I don't understand what happens, but it's okay. Okay. You see here the facets, damage, sagittalization, and progressive displacement. In this case of stenosis, we have changed the disc, and that is the result at 10 years. You see the restoration of the canal, and you see the good restabilization of the spine. This case, this woman, very damaged, sagittalization, bad facets, stenosis, spondylodegenerative. You see L5S1, I even don't care about it here. And so good restoration of the positioning with an anterior disc. And you see the 10 years, more than 10 years after, the facets are not very good, but reshape and less sagittal. And with excellent result, because you see ODI 12, low back pain 1.2, and leg VAS 0. This case is making a lot of things. He's 62. It's probably the only limit. And if he was younger, probably I would systematically do what we have done. After 60s, you have to decide if the patient is active enough and has no other problems that limits his capacities. This patient, you have a spondy, L5S1 degenerative disc, 4-5 spondy, 3-4 spondy, and stenosis. Okay, all the criteria we need. And you see the radiculogram with the compression, you see the instability inflection. Okay, we put 3 discs, we restore and we reduce. Most important, restore height and reduce the disc, and reduce when it moves. You see the capacity to restore the size of the canal. That's the facets. They are ugly. I admit they are ugly, but whatever. That is pre-op, that is post-op, and you see progressively the restoration of the facets, and 10 years, or more than 10 years, 11 years after, you have always a canal that is open with good clinical result, whatever are the facet aspect. And you see the mobility, the long-term mobility that we restore. I think it's better than a fusion of 4 level. Okay, that is a typical one, 59 years. Stenosis, sliding, bulging of the disc, posterior ligamentum flavum, bulging too, obstruction in the radiculogram, and good restoration of the capacity. The same case, always the same, with the facets completely sagittal, and you can restore a complete motion 10 years after, and that is your motion 10 years after with very good result. So there is a place for that type of conservative treatment in some very good cases, good bone, around 60, below 60. I will not go to 65 or 80 years old for that. Because the stress on the bone is important, especially during the reduction, and you don't want to break your vertebra by doing the distraction. But whatever, in that type of patients, still very active, working, sports people, is very interesting to preserve the future, because whatever are the facets, as you can see here, at the end, there is no influence of that type of aspect on the final result. You see here, 12 years after, the capacity of mobility for this patient, and 110 degrees of L1 race. I think it's a good preservation for the other levels, and also a good preservation for the quality of life of the patient. Okay, that is the result of this case. And you see the pre-op, and 10 years after, the quality of the evolution of the VAS and the ODI. Okay, 60 patients only, 48 before the surgery, 18 at the end, so 30 points of gain, which is exceptional, and also very good result at the end for the VAS leg and back pain. So it's a solution that is not to be ignored if you have a good bone and good active patient, and if you can reduce with a good technical way of reduction your displacement and perform your decompression. Thank you.
Thierry, it's Jack. A quick question. Most of the facets you showed were oblique facets. If someone had sagittally oriented facets and a very dynamic instability on flexion extension, would you trust the ProDisc alone to control that level, or would the orientation of the facet and the amount of motion influence your decision?
With a fixed core, you have the facets have no interest for the horizontal stability. They are with the distraction and the reduction, they are not touching each other. So they have no function for the horizontal stability. So we can, that's why they are not painful compared to a but it's not the same pathology. The facets pathology and destruction for the spondy is not the same as the facet degeneration for the stenosis. It's not the same case. Facet degeneration for stenosis is hyperloading the posterior arch because a lot of times the hypertrophy is coming for hyperlordosis, nothing to deal with what we see on the one-level spondy. A one-level spondy is a progressive instability that creates the destruction of the facets. But if you look 10 years after, all of them come back a little bit in a normal position and show a real emptiness inside. That means there is no real contact of the facet, and they have no more role in the stability. They guide, but they have no more role in horizontal stability. Okay, but it's my experience.
Thank you,
Always.
Thierry. We appreciate that very much. Our next speaker is Dr. David Ye, who's going to pinch hit for Dr. Chapman and talk to us about Coflex. Thanks.
Thank you, everybody. Thank you, Dr. Chapman, for giving me this chance to reintroduce Coflex interlaminar stabilization as an option to treat spondylolisthesis and stenosis. My disclosures: I am an educational consultant for Extant and for Sentinel Spine. So the history of Coflex, we know this product very well. First invented by Dr. Jacques Samani and first implanted in 1994. The important part was that in 2012, October, it was approved by the FDA here, and the 5-year follow-up was published in 2016, of which I believe Dr. Zigler was one of the authors. Then in 2018, the SCADA trial showed that, in fact, the Coflex, using that in conjunction with the decompression, was superior to decompression alone. It was especially notable that 4-time increase in walking distance. And now in 2024, Coflex has been implanted more than 250,000 times in over 60 countries. And my personal experience heading towards 1,000 interlaminar implants, I want to show you why it's changed my practice as an alternative to fusion for lumbar spinal stenosis and also as an alternative just to decompression alone. So the clinical evidence, as we mentioned, over 90 peer-reviewed published studies establishing the safety and efficacy of the Coflex device. Basically, it's a spinous process sparing bilateral hemilaminotomy procedure with interlaminar stabilization. But what does that all mean? I have the benefit of operating with a PA, and he was his passion is cabinetry, making furniture. And so as we started learning the Coflex procedure, I started implanting them in 2018. He came to me with this idea: what if we were better at the carpentry? What if we really looked at how the Coflex went in? What if we really measured 2 to 3 millimeters increase and got the bony work just perfect? And then I realized what we were really doing was interlaminar, interspinous joint replacement. And so that's where I see Coflex as being an incredibly powerful tool. So our target patient is moderate to severe lumbar spinal stenosis up to a grade 2 spondylolisthesis, have had great success with that, ODI greater than 40. The benefits: stabilization of the segment, continued motion preservation, but constrained so that it offloads the facet joints and increases the posterior disc height. The downside: there's the usual surgical risks, and sometimes I talk to people and they just hate to see the dura, they hate to see the nerve roots, right? But for me personally, I think talking to the dura, talking to the nerve roots, these days we're offering this procedure to patients under awake anesthesia with a spinal injection. And it's an incredible thing to watch as the patient's talking and breathing to you and you're doing the surgery, how much course and excursion you see in the thecal sac and the nerve roots. And it gets you to really understand that relationship. And it's a fascinating thing I've experienced. So the ideas are to restore and maintain the foraminal height after the decompression, thus preventing subsidence and restenosis, offloading, protecting the posterior disc and facet joints, and preserving motion. The indications for use: 1 or 2 level, L1 through L5. Sometimes off-label, I do see a nice spinous process on S1, and that's an option too. Obviously, the contraindications: you don't want to use Coflex whenever the bone is not suitable. In general, axial back pain, I agree, is not a great candidate for using Coflex. You really want to target those patients who you can either prove the level of their radiculopathy with transforaminal injections or something like that, or a detailed exam, of course, and their history. So being in just a solo practice in San Luis Obispo, halfway between San Francisco and LA, so very busy practice. My schedule's simple, do 2 to 3 surgeries, mostly at the outpatient surgery center, some in the hospital. Then clinic, 15 to 20 patients every afternoon. I have a PA, nurse practitioner, that helped me do the throughput because we're still operating on only about 20% of the patients that we see. And this is what I'll see in clinic, a patient that comes in and had degenerative disc disease and had a minimally invasive laminectomy. And you can see this patient is not happy. You see that the physical exam, and she specifically said, "Can you take a picture of my back? Because I feel terrible." And this is not an insignificant procedure. We call it the shark bite. You know, you basically remove everything, vacuum up all the ligamentum flavum, and as I discussed with you just recently, now you know the thecal sac is moving. Now it can't move at all. You know, it's completely scarred to the posterior elements. So then you have this case. I saw a local surgeon, L4-5, stenosis, some listhesis. He's 75 years old. He was a retired police officer. He's also a Parkinson's disease patient, and so a real high complicated, difficult case. And so when he saw me, he had 3 through S1 fusion and immediately broke down above and really just miserable. The life was ruined. We ended up doing a lateral approach and instrumenting, removing some previous screws, adding up, and just never could get this guy happy again. So a real change in his life. So this is a 79-year-old who many years of left leg pain. He's a higher risk surgery candidate on Xarelto for atrial fibrillation, and he has had a discectomy at L3-4 and has this residual stenosis here. And he talked to me about Coflex, and in fact, that's what we did. We did it as an outpatient, and it was done in under 45 minutes, and he was home within 2 hours. You see the incredible movement that he has. I think, and I'm very interested to hear Dr. Alamin's talk about Limiflex afterwards, because the criticism of Coflex is it puts patients into kyphosis. But if you, in fact, get the U close enough to the thecal sac, 1 or 2 millimeters away, I haven't had that problem. But I do get flexion extension films on everybody to make sure they are not hyperlordotic at the level, because that's the weakness of Coflex. It can't open anymore. But Coflex is very powerful in extension. And so this was an email I got from him, and this was in 2019, so early in my career with Coflex. Dr. Yates, pleasure seeing you in follow-up. 6 months afterwards, I installed 500 square feet of sod in my backyard with the pictures below. You said you would not have approved of this project, but I felt so damn good I had to do something physical and enjoy the freedom of being pain-free. So I was getting feedback like this in droves. In California, Dr. Lemon, you know, people will buy us wine as gifts. I was getting cases of really good wine. You know, that's very incredible. So, and this is another heartbreaking case, a minor listhesis at L4-5, and you know, the patient just, and this is in my community, we see this, you know, hours and hours of hand holding, you know, spinal cord stimulation trial, percutaneous or open. Of course, this patient was a retired social worker, but she had a Blue Cross commercial insurance, and there was a copay associated with this, and you know, that's decimating to the patient. So really, it makes me always think that motion is in fact life, and that's why I'm here and happy to share this with you. Thank you.
Thank you, David. And our last speaker for discussing Spondy is Todd Alamin. He's going to talk to us about the Limiflex. Can you find it?
Let's see. Where would that be here?
Here comes Corey.
Great. Great. Well, thanks for asking me to speak. Yeah, there we go. So I'm going to stick to that case that we were talking about. What's a 1.5 Degen Spondy? I don't know, I think it's probably a grade 1 spondy extension and a grade 2 spondy flexion. So I'm going to talk about a different treatment strategy, what I'm calling a spondyloplasty, or doing a direct decompression and using the dynamic sagittal tether to address that. I'm conflicted. I was one of the developers of the device, and I'm a consultant and stock owner in the company. But let's think about what we're trying to do, right? We want to make treatment decisions that are ideal for our patients, and that's not always possible. But in theory, what we try to do is we try to fix the problem so that it doesn't come back. We try to disrupt the anatomy as little as possible, and we don't want to cause other problems, right? So it goes back to the KISS principle. Keep it simple if you can. So as I was speaking with Dr. Bervin about earlier, there's lots of different types of degenerative spondylolisthesis, and particularly that's the case in grade 1.5 Degen spondies. The way I think about these cases is they're either similar to the one on the left that's amenable to a direct lumbar decompression, or it's similar to the one on the right. And I'll just direct your attention towards the foramen here at the L4-5 level on typically the concavity of the little fractional scoliotic curve. There are people that have vertical foraminal stenosis that you can't directly decompress. So I'm just going to talk about the ones that are amenable to a direct decompression because I think it's important not to excessively generalize on this stuff. So here's a patient that's one such patient, prior smoker, active guy, 65, a lot of back pain, a lot of leg pain, stenosis in the typical zones, the central and subarticular recesses. The foraminal stenosis is amenable to a direct decompression. He has a fair amount of motion on flexion extension films. So what would be an optimal strategy for this guy? You need to decompress the stenosis because, as was pointed out before, that's the cause of their symptoms. But how do you deal with that increased instability that's always going to happen when you resect structures that are posterior to the center of rotation? Right? So what do we do about that? You could do a fusion or not. If we could not do a fusion, that seems like that would be optimal. You could use a device that was either load-bearing or load-sharing, right? And we know that load-sharing devices tend to have less of a complication profile associated with them. You could use a device that bears axial load or not, and it would be better if it didn't, because those loads that are not axial are a little easier to predict and lower. And finally, you could have one that has a mechanical hard stop within it or not. Again, optimally, you would have one that didn't have a hard stop within it. We know a lot about degenerative spondylolisthesis, and we know that the important feature here in controlling sagittal plane stability is not the disc, it's the facet joints. Those are the structures that constrain sagittal motion, and they do so better when there's more surface area that's overlapped, and we know that that's in the extended position. In the flexed position, there's less superimposed surface area, they're less able to bear shear loads, and this happens in these unstable patients during activities of daily living in the so-called high flexibility zone. So to address that, we developed this dynamic sagittal tether, which biases the segment into extension after you do a direct decompression. And so the idea there, again, is trying to take advantage of this coupling of flexion and translation by putting the facet joints in a position that's best able to constrain the shear forces on the segment. And according to that other heuristic we just talked about, it's load sharing, it's not load bearing. There's not a hard stop within it, and it doesn't bear axial impulse loads. That all translates to a quicker recovery and clinical success that's superior to TLIF in a per protocol analysis in our big trial. So we did a trial involving some of you in the room here, and thank you for that. We analyzed here 300 patients that were in the trial that were treated with either a decompression and a Limiflex or a TLIF. We analyzed these patients by a clinical composite success criteria, which combined these factors. When we combine all of these factors together, which is that they could not have an adjacent level surgery, they had to do really well on the Oscar Disability Index. It had to improve by 15 points. They had to not have a device integrity problem, and they had to not have a new neurologic deficit. You can see that in the first row here, the Limiflex group did significantly better than the fusion group at 2 years of follow-up. Here's an example patient that I discussed previously. This guy's 5 years out from surgery. You can see that he still moves. He has not translated further. His Oswestry Disability Index, his back pain scores, his leg pain scores have done extremely well through 5 years, and he's very happy with the result. Here's again that flexion extension animation pre-op compared to post-op. So he still moves, but during the relevant zones of activities of daily living, he's more stable because he's in more of an extended position, and as a result, he hasn't translated. So in the end, we like to keep it simple if we have to, or if we can. These patients present with stenotic symptoms. We're all very good at doing decompressions directly, as long as we're hand surgeons in training, as Dr. Chapman was speaking about previously. And then, yes, these patients, I think, have to be stabilized, but do it in the least disruptive way. So for me, the answer is pretty clear for most grade 1.5 Degen Spondys. Yeah, I think the Limiflex is a good solution for that. Thank you.
So, Dr. Sasso, are you online still? Can you give us a verbal before we go to the lab?
Yes, Jens, I'm here.
So I know you're conflicted. You're a master arthroplasty guy. You've participated in the Limiflex trial. You know all of those devices. Give us your words of wisdom. I've declared your bias, so just speak freely. What is your thought? How do you guide us?
Yeah, so I was involved in that trial as one of the largest enrollers in the FDA trial. All of my cases were done in our surgery center. They were all grade 1 degenerative spondylolisthesis with bilateral L5 radiculopathy. So I loved Chris Kepler's talk because I think we fuse way more degenerative slips. And for unilateral L5 radiculopathies, I simply decompress them. But with bilateral L5 radiculopathies, my standard has been to fuse them because I think I cause too much disruption in my surgical decompression. So these Limiflex patients were all those that I would have fused. And all of them were done on an outpatient basis. As Todd said, the outcomes were really good. I think the question is how many require a fusion? And in my hands, I had 3 that I ended up fusing. All 3 of those were after 5 years, 5 years or greater after their decompression. And all those patients said, you know what? I'm glad I ended up having the outpatient operation, and it gave me 5 years where I wouldn't have needed a fusion. And now that I need a fusion half a decade later, they were okay with that. So overall, I was very impressed with the Limiflex. I think my patients have done very well.
And do you mind commenting on the 2 motion-preserving devices? I'm conflicted. I'm, I think, a consultant for Extant also, just like Daniel. But I've done both. I was not as big an enroller, but a grateful enroller to Limiflex. I completely agree with you. Both did very well. In my hands, it's a game changer for me personally to not fuse patients. So can you kind of comment on your thoughts of the differences of an interspinous process spacer that has a gentle distractive effect versus a compressive device, a posterior elastic compressive device?
Yeah, I'd have to defer to the biomechanical experts on this. I don't know. I don't have a lot of experience with Coflex. You probably have way more than me, Jens. I've done a handful, but I'm not. I don't think I can comment really on Coflex versus Limiflex.
I was trying to pull up the slides of Dr. Alamin. Todd, what do you quote patients as a 5-year reoperation rate? Just the nutshell data that you give them.
So what we saw in the IDE trial was at 2 years, that reoperation rate was about 6 to 7%. The patients that we have at follow-up at this point, I think we've looked at it to 4 years, it was about 11%.
And then same question, and we'll have to go to the lab in a second. We're half an hour behind. Dr. Ye, what reoperation rate do you quote patients with a Coflex spacer? Let's say 5 year, something like extrapolated.
Yeah, so we've done around 825 interlaminar levels in the last 6 years. And what I've noticed is that because we haven't enrolled in a study, we do patients for their symptomatic level. So we've had to come back more often, but they come back and they're happy to have another Coflex at another level or another decompression at another
So
level.
let's just specify the question. Sorry to be pinpointing you. At the target level, the index level, what is the reoperation rate?
It's very low, less than, I would say less than 5%.
I think the larger case series that I saw were 5 to 10%. I tell them 15% by 5 years. That's my extrapolation. Dr. Kepler, any thoughts on these devices and what reoperation do you quote patients with a subtle degenerative spondy that you've done decompression on? What reoperation rate using sport trials and your own data by 5 years would you quote a decompression patient?
I don't have any experience with the inner spinal spacer other than taking them out, but I tell people at 10 years I'd expect 20% of people to need another surgery at the same level, and honestly, a lot of times for me, it's more about telling people like it's okay to not do a fusion, and nothing if you hit out. And you got to go back in. You got to go back in. It's not bigger. It's not a bigger, more complex surgery than if you had to do it up front. And maybe 8 times out of 10 or 7 times out of 10, you don't have to do it.
Dr. Bervin, you gave a great talk last night about large-scale data analysis, machine learning, and one of the things that you really hit home to all of us was the clustering of data, that undue clustering. Degenerative spondy is a great example of that. We have variables that are measurable, disc height, translation stability, coronal instability, facet joint angles, facet joint gapping, etc., angulation. Why can we not standardize and subdifferentiate this simple common disease entity better to better target patients for individualized and beneficial treatments?
Yes, I think this is really critical, is that the diagnosis of degenerative spondylolisthesis clumps together a lot of very heterogeneous elements. Patients with foraminal narrowing, patients with segmental kyphosis, patients with more than 3 millimeters of motion, angular motion versus translation, as you pointed out, anatomic characteristics, radiomics with different tropism of the facet joints. I really think, again, we're looking at means. In a mean, patients do better with surgery than non-operative care. And we're not able to differentiate between, there's almost no area of medicine where there's more variation than our treatment of degenerative spondylolisthesis. We saw it just here. And I think that there probably are clusters of patients who do better with a fusion, clusters who do better with a flexion-mediating limiting device, clusters who do better with an extension-mediating device. And it probably has a lot to do with, so what we published in the European Spine Journal is the following criteria. Back versus leg pain, we think, is probably important. The location of the foramen, central lateral recess versus foraminal, as Todd really nicely showed. The segmental kyphosis and alignment, and the degree of motion and instability. Those were the criteria that I think we can make a better granular designation of which patients for whom the specific treatment is appropriate. Because I don't think any of these are right or wrong for everybody. I think we need to be much more granular in who we apply this to.
I think it was spoken from my heart. Well, we're half an hour behind. I apologize to our audience, and thank you for the speakers. A great potpourri. I want to recognize Dr. Marnay. What an honor it is, and so cool to have his data. And sorry for the technical difficulties. Can we pivot to the lab for a second and see how that's working?